No, nope, nope, nope. She's doing it a lot different. There's some lessons learned, obviously, but what'd you do with? Oh, there it is. I think Amber said, "I'm going to hide that."
I didn't have enough open time. Too many eyes, too many open.
Just a couple of minutes, and we'll get going.
If you can't scroll through it, then you just start rambling and talking. That stuff's not even on the slides.
I gave you the slides. Why would I talk about them? Right? These are just talking points. Right? Do you think the entire curriculum could be in the few words that are on the slide?
No, I know it's not.
Okay. I know you're just aggravating me too, right? Yes, Luke.
You talked about the Venturi.
Yeah,
I think they also use the Bernoulli effect as well.
that is the Venturi effect.
No, the Venturi effect is coming.
Yeah, because
Is this high pressure here bringing
they don't have to mask it.
bringing tube, or in this case fuel. So if this was a carburetor, taking it from the fuel tank.
You've already
Because this high pressure here, the Bernoulli effect is when you narrow that down, you end up with higher pressure on the other side.
Yes.
Airplanes work the same way with the wing. This, because they have a higher pressure here than they do down here. That gives it
Provides it the lift. Okay. Yeah.
I don't know. I was expecting you to talk about that, but I was just curious.
That's some great trying to think of that. Oh. What's the math course? Differential equations. In the math course called differential equations. Yeah, they study all that. It's crazy, isn't it? It's kind of cool though. That's why this room's cool today, because of those principles. High pressure through an orifice, therefore becoming low pressure. Law of thermodynamics, that low pressure will get cold. It's everywhere. It's everywhere. It's pretty cool. You also get those effects in the heart, because you'll get a swirl, an eddy current behind a valve, and it'll just sit there and swirl but not get ejected. And so it becomes stagnant, and we'll get a clot, and the clot gets heavy enough it falls out of the eddy, nope, to the brain. You're like, where'd that come from? What's been building in your heart for the last 6 days?
I didn't even think about that. Clot would
Yeah.
Is that what clots?
Or a thrombus in the, so if you get a buildup of plaque in an artery and you're having to narrow the passageway so it accelerates, the fluid accelerates, but on the backside of that blockage you get a low pressure area or an eddy current, and it sits there and swirls and builds a clot, and then it dislodges, and now you got a stroke
People typically
or a PE.
Do people typically have higher blood pressure when they have a clot?
It doesn't matter.
Well, what is it typically?
Depends on where you measure it.
That's where the Bibles they do.
Say they're pulse on their hand.
Because I think there's
You will find if they got an occlusion that like the right side will have a clot, or the right side will have a higher pressure on the left side,
one.
So it's probably because the veins stretch.
or can't stretch. It's usually because they can't stretch. But when they do stretch, it's an aneurysm. And so we get this bulge in the vessel that every time we get a pulsation is absorbing our forward pressure. Make sense?
Yeah.
You're on track, dude. Love it. Love it.
Veins normally have some
Elasticity.
elasticity.
But if I get a bulge in it,
It's stretched to its
so
max.
yeah, it goes over here, and that bulge, that pulsating bulge is taking my energy away, not pushing it forward. So a person who's got an aneurysm in their belly, you can kind of see the bulge sometimes. It'll pulse with their pulse. But you go to the feet, you don't feel a pulse. Because the energy's being absorbed here, therefore there's no forward flow.
Smooth muscle tissues is absorbing
Mm-hmm.
pulse. That's interesting. I didn't know that.
Well, there's 3 layers to an artery: tunica intima, tunica media, tunica adventitia. And once it's tearing through those 3 layers, that last layer is beyond the smooth muscle. It's just that outer fibrous coating of the artery. Mm-hmm. Much like a water hose that's coming apart in the hot sun, gets that big bubble on the side of it.
No, we use like metal hoses.
Yeah, yeah. Okay, so let's get going. Great questions. Jonah, you okay? I'm so sorry. I mean, I feel bad about that, and I'm going to apologize publicly.
You didn't
It's just, you know where I'm coming from,
You
and
were saying what you're saying, and I was like, well, that didn't make sense because they only said what they said.
and I need you to do that. And it's only amplified in the paramedic side of life because there's so many bad habits. If I had not addressed that, and that question came up on a test on the registry, I would hope so. I would hope that question would have been caught in the test prep process that the registry does. It takes a lot of money per question on the registry because it's a group of people like me and others, and who we sit down in a room and we'll spend all day on one question, massaging that crap out of it. And that's trivia, that's crap. What's the purpose? So, but this goes for all of you. When you get out there, outside these walls, I don't have any control over you. You'll hear different things like that. And I could go for days talking about the myths that you will hear that aren't true. And they tend to stick with you because they're spoken in high stress environments when your dopamine and adrenaline is really high in your brain. And so it makes a better memory than it does sitting here in a dull classroom. And so that's hard to combat. I often say you'll do better before you go for your internship experience. Well, just wait till y'all go do your ride outs and you come back and tell me the stories, and I'm gonna go, oh my God, you did not do that, did you? And you're like, yeah, that's what he said do. I'm like, never do that again. Never do that again. And I try to hit it off before you even get out there because I know what they're gonna do to you. Like, never take blood from the IV needle to do a D-stick. But they're going to show you how to do it. Okay. So we went from distress to failure, and now we're going to arrest. The worst possible respiratory condition you can be in is called respiratory arrest. It is also the easiest to recognize. Okay? Arrest means it's not happening. There is no respiratory effort. Please understand, agonal respirations do not count as respirations. That occasional gaspy inhalation that you might hear in some victims is not respiration. There's a rule here. You can have a heartbeat, you can have a pulse and not be breathing. For a little bit. You can have a pulse and not be breathing for a little bit. But the flip side of that is, if you don't have a pulse, you're probably not breathing. There may be an exception to every rule out there, but as a general rule, if you're in cardiac arrest, you're also in respiratory arrest. But you can be in respiratory arrest and still have a heartbeat for a little while. Depending on how much resilience the patient has, we'll let you know how long they can go before they go into cardiac arrest. If I find a patient in respiratory arrest, I need to find out real quick, are they in cardiac arrest? And if so, I will start compressions before I start ventilations. Did y'all hear that? We're going to reinforce that in the CPR portion of the class. If I find someone in respiratory arrest, I need to find out real quick, are they in cardiac arrest, meaning no pulse? If so, I need to start chest compressions before I start ventilations. But if they're in respiratory arrest and I check a pulse and they have one, let's just go ahead and start breathing for them. You'll see this over and over and over and over for the next year or two as you go through this training. the concept of airway, breathing, circulation. And that ABC approach to patient assessment means this. Does my patient have an airway? And by that I mean, is it open, patent, meaning has it not collapsed? Has it not got something stuck in it? Do I have a good airway? If the answer is yes, then the next thing I say, are they breathing? If not, breathe for them, then I'll check the circulation. But if I find my patient's not breathing and they don't have a pulse, I will start chest compressions before I address breathing. That's kind of a, people say, well, that's awful confusing. Think the American Heart Association, because they approach cardiac arrest in a CAB approach. Chest compressions, then airway and breathing. It doesn't do us any good when we're trying to learn. I wish both of them would go away, because what have I told you? Give the patient what they need. Give the patient what they need. If they don't have an airway, provide an airway. If they don't have a pulse, provide a pulse. If they don't have respirations, then, or ventilations, I should properly say, then ventilate for them. If they don't have sugar, give them sugar. If they don't have oxygen, give them oxygen. If I can't do that, get them to some place that can do that. Immediately intervene with back valve mask ventilations and supplemental oxygen. Will a patient who has not been breathing, the word for that is, you know it, I already told you. What do we call not breathing? Huh? Apneic. Apneic. Or the patient suffering from apnea. Same word, just two different forms. The A means without what? Without breathing. They're apneic. My question though is an apneic patient a hypoxic patient? Well, maybe not in the first 20 seconds, but as soon as they stop breathing, does their oxygen saturation begin to fall? And do CO2 levels begin to climb? No, go Billy. No. Now hypoxic drive is when they suffer from a chronic respiratory disease. But there will be we hope there's a respiratory drive trying to work, but unless they've knocked it out with fentanyl.
I don't know where I got it.
No, it's all in there. It's all in there. A lot of words, man. A lot of words, all right? And they're all scrambled up in here and they're floating around in this word cloud, and you just go pick one out and say, does this one work? Nope. He said no. Go grab another one. Try to make it work. Any questions over the three conditions that the patient can be in? Distress, failure, arrest. So let's talk about some specific diseases. We already have, so we ought to be able to go through this relatively quick. Emphysema and chronic bronchitis are the two that fall under that umbrella called COPD. Remember that from yesterday? I'm going to try to go quick here, guys. So let's look at a normal set of alveoli at the end of the bronchiole. What word should be in front of bronchiole right here? If it's a better descriptor, what word should be in front of bronchiole? Terminal. Remember, it's the last division. It's the last bronchiole before the alveoli. This one's normal. It's pink, it's inflated, it's got surfactant, it's got a close capillary bed running alongside of it. Gust diffusion takes place relatively easy. I don't want this to collapse. It's called atelectasis if it does collapse. We like to keep these open. And as long as everybody's healthy and wise, it'll stay open. When we get emphysema, the bubbles start popping. So what is the telltale sign of emphysema? What's the diagnosis? What's the criteria for diagnosis? Alveolar destruction. So emphysema, we take away the tennis court. We rip up the tennis court. We're losing surface area. The telltale sign of emphysema is decreased surface area, or another way of saying alveolar destruction. And they don't come back. They don't come back. If you can watch this unfold when you pour up a soft drink in a glass and you see the foam on the top and you let it set and the foam goes away, you're actually watching emphysema highly accelerated. Those really small bubbles become bigger bubbles and there are no bubbles. You can kind of gauge, can't you, how healthy your soft drink is by how much it fizzes when you pour it? You ever had one that sat there for a little while and you open it up and it's like, no fizz, I'm not even going to take a drink of that, throw it away. When you go to the soda fountain at the cafeteria and you hit it, you know how good it is if you have to hit it several times, right, to let the fizz go away? How healthy is your patient? Lots of fizz, lots of surface area. So that's emphysema. Chronic bronchitis, the alveoli are pretty good, but we get a lot of mucus building up in our bronchial tree. I bet everyone in here has had acute bronchitis. Where you had that chest cold and you coughed up stuff for a few days and had a little fever and your mom might have said it settled in your chest. You're raspy, you cough up, you get mucus coming out, you go spit. That's acute bronchitis. Chronic bronchitis is they have that all the time. They have that all the time. Can they have both? Can they have a little touch of both? The answer is sure. Sure. Why is the body building all of this mucus? Well, it's trying to protect itself from all the toxins of usually smoking. But it's chronic. They don't clear it up. Now, if they quit smoking, depending on how far the disease has progressed, all the research says there's never a bad time to stop smoking. You will improve immediately. But if you smoke long enough, you can actually have a cellular adaptation that changes the lining of the trachea and the bronchial tree from an epithelial style cell to more of a calloused style cell. Like the big old heavy calluses on your big toe, that's what the inside of your trachea starts looking like. Instead of nice, soft, pliable with all these cilia that sweep things out, no, we just harden it. It just hardens it off. So when it hardens it off, imagine this bronchial tree that used to be really elastic, Luke. You talked about elasticity. It's smooth muscle that can expand and contract depending on needs. You turned it into a callus. Can it expand and contract now? No, and it just builds all this mucus gunk. So you'll hear this. When you're listening with a stethoscope to these patients with chronic bronchitis, you'll hear this go. It's just, you're like, God, what is living in there? What is living in there? And they'll cough it up. And it probably won't be pink frothy, because this is not congestive heart failure. It'll be bloody, blacky, mucusy, if they can get it coughed up. A lot of these patients tend to run a little bit dehydrated because they just don't drink well, they don't eat well, they have poor nourishment. And if they're not well hydrated, new term alert, kind of, this mucus becomes increased viscosity. The viscosity of this mucus gets higher. Your engine oils are measured in viscosity. A 90 weight engine oil sticks to that wall better than a 10 weight engine oil does. If you ever watch an oil commercial, this additive will increase viscosity. It just means it makes it thicker and it sticks better. Same way, same thing happens in the mucus. When the viscosity goes up, it sticks to that better. When we give this patient oxygen, is it dry? If I give them oxygen out of a cylinder, is it dry? It's 100%. It has humidity of 0. They do not want moisture in those cylinders because they would degrade and break down, and it'd be all bad if there was water in that cylinder, right? So when they fill that at the filling station, so to speak, it's running through dryers that take all the moisture out of the air. When I give that to a patient, it's dry. If I give him drier than normal air, what happens to that mucus? It turns to boogers. It gets hard. It dries up. It turns to cement. So it's best to give these patients humidified oxygen. And that means instead of running it through tap water, I run it through distilled sterile water. And it puts humidity in the air. That will decrease the mucus, allow them to cough that up easier. When you go in their home and they have that oxygen concentrator like Margaret had, Sterrett, at the opening case, I hope she had a humidifier hooked to that. And all that is it blows the oxygen through the water first, and it adds moisture to that oxygen. Now, if she's not changing that with clean, sterile, medical grade, distilled water, and she's just refilling that out of the tap, she may be picking up pathogens from the tap water, especially if it's a non-chlorinated source like a spring out back on the side of the hill. She could be breathing in pathogens and causing some really funky pneumonias. Not too bad of a problem anymore, because most of those oxygen concentrators are serviced by home health and they'll leave them plenty, but it can happen. So you need to kind of be looking at that. If you look over there at that humidifier and it's got green mold on the top of it, that's why you're here today. And that's part of seeing size up, isn't it? I've seen oxygen tubing that was so old that algae looking stuff was growing in the tubing from the moisture that was in it. It's like, when's the last time you changed your tubing? Well, it still works. It's got mold in it. They'll wear this so much that they'll have the lines in their face from where that tubing sits on their face. It's kind of sad, isn't it? So this is just already what I've told you. I've talked about pursed lip breathing and all that, so we can move right on through this. Accessory muscle use, tripod positioning, gasping for air, and got him some Marlboros there. Still got one burning in the ashtray. I've been around smoking all my life. I've never done it. Thank goodness I don't have that habit. Obviously, it's a very hard habit to break, because I cannot imagine sitting in that condition, looking over there and saying that's the cause and not stopping it. Perhaps I have other vices that you could compare that to, but the devil's disease, man. This is a bad one. If you're not smoking, please never start. This is that CPAP I mentioned a bit ago. They got to be conscious. They got to know what's going on. They got to be breathing on their own. And there's some air under force going to this. That's the dial, kind of set the regulator. This is going to help that patient breathe. Now, I don't think this is a bronchitis or an emphysema patient, do you? But they're having trouble breathing for whatever reason. Maybe an asthma patient. See that frightened look on her eyes? Now, if you're struggling to breathe, do you really want this on your face? But after you've had it a couple of times, you do want it on your face. I had a kid, and I cannot remember, when I say kid, infant kid, young, not walking yet kid, that I went on, and he had some condition he was born with. I don't remember if it was cystic fibrosis or what it was. I don't think it was cystic fibrosis. Anyway, he needed a nebulizer. And I remember hooking the nebulizer up and turning it on, and that sound that we talked about, that this kid raised up and opened his mouth, raised his head. He was coming for the mask as much as the mask was going to him. And I was like, oh my God, this kid's hungry for this mask. Because he knew what? He knew when he got that mask on, it was going to help him. And that told me right then and there, this kid's used to this. He wants it. He wants it. He was coming after it. And he wasn't even able to walk yet. And so that was kind of sad to think of a kid struggling to breathe that bad. But when he was in his bed before that all got hooked up, he was...
What was his condition?
I can't remember what it was. It was chronic. He was born with it, kind of thing. Obviously, it wasn't this. It was probably some reactive airway disease, which is asthma, but we don't say asthma if they're kids. We call it reactive airway disease because they want them to be drafted. More about that later. The chronic bronchitis, I talked about it. It's the buildup of the mucus in the bronchial tree. So the cough, we talked about the cough. Look at their trash can. The blue odors, the pink puffers, we talked about that. Let me mention something about trying to give these patients O2. If they need O2, they need O2. They probably do need O2. You're never going to get it up there to that magic 94. Remember, this is a chronic disease. They're just kind of stuck with it. You're only going to get them better. You're not going to make it better. So, Jonah, to your point, even with the non-rebreather at 88, I mean, okay, I just can't do any better than this. And you're not going to do any better than this. These people live in that chronic hypoxic condition, which, Billy, leads to what type of respiratory drive? Hypoxic drive. If I just keep cramming the oxygen to them for an extended period of time, what am I going to do to their desire to breathe? Yeah, I can kill the respiratory drive. Takes a while, though. Don't think it's going to happen in 5 minutes. I'll always monitor and assist as needed. Consider the use of CPAP. Just once again, a lot of these patients will already have it at home, and they're like, it didn't help. Okay, well, let me try mine. They may have a better CPAP BiPAP machine than you do. Just depends on who they are. Okay, that's the case study we went over. Let's talk about asthma. This is not a COPD disease. Some people try to classify it as one, saying, well, if you've got asthma, it's a chronic condition. That's not what I'm getting at. When I say chronic, it means you live with it all the time. You're activated all the time. Asthma is episodic. Asthma comes in episodes. Does anyone in here suffer from asthma, if you care to share? You do? So it's relatively common. Do you have exercise induced, or do you know what your trigger might be?
Yeah, like when running.
Exercise induced asthma.
Yeah, or seasonal,
Certain pollens.
that kind of stuff.
And so that's the deal with asthma. There's usually a trigger mechanism. May not know what it is, but there usually is a trigger mechanism. Asthma also has another term, and here it is: reactive airway disease. You may talk to a mom or a dad about little 3-year-old Johnny who looks like he's asthma and an asthma attack, and you say, does Johnny have asthma? And they go, no, he doesn't have asthma. Oh, well, it looks like asthma. No, the doctor said he had reactive airway disease. Same thing. They will not put asthma on a child's chart as a diagnosis. If they do, it dings them for life. A lot of children who have, AKA asthma, reactive airway disease, it will leave. It just tends to, like, I haven't had an episode, I guess I don't have that anymore. But if it's documented as asthma, it will follow them in the charts forever, all the way to the military service. So if you get drafted or join the military and it's got asthma on there, they're going to go, I don't know about all that. I don't know if we need you. Plus, it could be some insurance implications and things like that as well. So how's yours diagnosed? Reactive airway disease or asthma?
I say asthma, but I bet it says.
I bet it says reactive
Because
airway.
I did have it when I was a kid, and I ended up growing out of it, and the older I got, it came back.
Okay. Then it never really left. It just
Yeah,
took
it
time
took
off.
time off,
It just
yeah.
took time off. Well, at least you now know what the trigger is. So what happens is something will set the attack off. We may or may know what it is. Anxiety will do it. Pollen will do it. Pet dander will do it. Dust, mold, getting a cold, exercise. There's just so many triggers for it, what this will do. And what happens is, new word alert, bronchospasm. So Luke, instead of it opening or closing, it's just spasming. It's just sitting here vibrating. It's just a spasm of that. Gus, beta 2 agonist, we'll shut it, we'll stop it. Usually. They will have more mucus. Because of the spasm, you will hear wheezing. They usually don't get this mucus coughed up because it's a real thick viscosity. On an asthma patient, we must give them humidified oxygen. Please give them humidified oxygen, if at all possible. Because we want that mucus to get loose, not thick. Guys, it can get so thick it locks down like glue. It's already sticky enough, but it can just harden in there. Remember, a silent chest is a dead chest. So look back to your deal once again. As those bronchial trees go into a spasm, there's resistance to airflow. And if I can tell you a story, it might help paint the picture a little bit better. I was curious, Jordan, what set yours off? And you said environmental and exercise. I had a student, I had her as a paramedic student, but she was in EMT class like yours, and we had this big skill day going on where we had to test all of our skills, and everybody was all super nervous. And I don't know why any teacher would create an environment where everybody was super nervous. This is bad enough without adding to it. But this teacher loved to teach by intimidation. And no, you're not intimidating. It's intimidating enough without purposely making it so. This girl was under high stress. I was teaching paramedic. I walked down the hallway, and there's a bunch of people gathered around a student who was slumped against the wall. And I'm like, I guess I should go see what that's about. So I walk over there, and everybody's like, Brandon, she can't breathe. And I look at her, and I'm like, do you have asthma? And I could tell she was gasping for air. She was, give me one of your stethoscopes that all of you are carrying around, and I listened to her chest. Where did I go? Second intercostal space, right and left. I could hear it. I could hear air. Heard some wheezing though. I said, do you have asthma? Where's your inhaler? She couldn't even form a word. She didn't even bring her inhaler with her because she hadn't had an attack, Jordan, in years. And now all of a sudden, she's having an asthma attack. I then moved further down the chest, auscultating for lung sounds. Once I got about here, silence. Silence. Oh, yeah. Call 911. Somebody call 911, tell them where we're at. And then one of the adjunct faculty, who happened to be a paramedic, walked by me and said, Brandon, you need some help? I said, yes. I said, I know for a fact there is some albuterol in that storage closet that's still in date. We used to take drugs in that were expired so you guys could see what they look like. I looked at some and I knew that it was good. I just put it up. I think fate had something to do with that. Go get that. Go get the oxygen. She needs nebulized albuterol. So we got to give her albuterol. Didn't do it. What she ended up in is this last condition here. You need to know this. Status asthmaticus. Now what's the word status means? It means static. It means steady. It means continuous. She is in a continuous asthma attack.
That's when you go to the steroids.
That's when you get real.
Even intubation, right?
All the way up to intubation.
Intubation. Or an asthmatic person one time, she woke up, looked at me in the eye, and asked me to take the tube out.
And yeah, I'll tell you why they don't want you. I'll tell you why they don't want the tube here in just a second. That means she's had one before. May I say this, y'all? If you arrive on scene and the asthma attack is still happening, guess what they're in? Status asthmaticus. How come? Well, think about it for a minute. If you called me because you're having an asthma attack, you dialed 911, you talked to that person dispatched me, I drove 7 minutes across town to your house, I found your house, I got in your house, and you're still having an asthma attack. Oh crap, that's too long, isn't it? And there are some definitions. An asthma attack that lasts longer than 5 minutes. Who's counting? An asthma attack that doesn't respond to treatment. What treatment? I'm just looking at it like this. An asthma attack that you can't break or I can't break. If I can't interrupt that or you can't interrupt that, is status asthmaticus until proven otherwise, right? This is a life-threatening condition. This girl is in the floor, silent chest, at least majority of it was silent. I can tell you she was not moving air to the alveoli. Did I need a pulse oximeter? Did I need to count her respirations for 30 seconds to see what her respiratory rate was? Did I need to take her blood pressure to see what her blood pressure was? Did I need to give her oxygen? What good's the oxygen if it's only getting to here? What did she need? She needed bronchial tree relaxation by whatever method possible. My treatment's not working. By this time you could hear the sirens coming. Does that help her? Hearing sirens coming to her, does that help her? No. You don't need the siren coming down this driveway. Goober. You don't need a fire engine, but they'll bring one. How many firemen does it take to get a little old lady off the floor? Well, apparently 14.
The lights are cool.
But the lights are cool. You know what's super cool? You know what's super cool? Now, when your ambulance pulls up next to my ambulance, the lights will get into sync with each other. I see that on TikTok, and I know where that's at, and I want to comment so badly, but I don't want to get fired. I want to say, who the cares? Why not turn them off, and they'll sync really well? Because I can't see as a pedestrian driving down the road or a motorist driving down the road because your LEDs are so bright that I am being blinded.
That sucks for you. It sounds like a new goal.
Turn the suns off. And you know, there's actually a fire department that said, those are too damn bright. Send them back to the manufacturer. Said, dim them down to an acceptable level. That was plain old fire. Said, these are too bright in the middle of the night. Calm down, Brandon. Stay on track. I get some people who are here just to see the lights. I don't know. Thank you for bringing me back to reality. Yes, go ahead.
If their inhaler isn't working at all and they're still in status automatic,
The status automatic. You know, I got to move, right?
would you keep trying that inhaler?
Yes. Continuous albuterol updraft, just hoping that at some point we get it down in there. Now, I could probably assist her ventilations and nebulize with that 15 by 22 port to hook that nebulizer to that bag and push that down in there. If that's all I've got as an EMT, as a paramedic, I can give her a shot of terbutaline going from the backside, bronchodilate. I can also give her epinephrine. I can pull out epinephrine. I could even pull out morphine because morphine is a smooth muscle relaxant. So where do I find smooth muscle? I find it in tubes. Is this a tube? Yes, it's a tube. And you're going to have medical directors freak out because you gave morphine to an asthma patient. Hey, probably not a good idea because the drive to breathe needs to be here and morphine will take the drive to breathe away. I've got control over her drive because I'm a paramedic. If I want to, I can paralyze her and stick a tube in her throat. I mean, at the paramedic level, I got all stops. I got it all if I need it. Start basic. They get here, they rush her to the hospital. They don't do anything any different than I could have done out of a supply closet here, which is not necessarily a good thing. She gets to the ER. They go with treatments. She's still just barely able to stay awake. She is fatiguing quickly. She's about to go into, is it respiratory distress? Already been there. Respiratory failure? Already been through that stage. What door is she knocking on? Respiratory arrest. If you were an EMT on that scene, you would want ALS there. I would like to intervene before she arrests. The EMT level, you may not have that capability. You hope you can do something, but you may not have that capability. If she arrests while she is swollen and bronchospasming, am I going to do any good with the back valve mask? Probably not a whole lot of good, am I? I need that direct airway control. They get her to the ER. They pull out tubes. They're ready to sedate her, paralyze her, and intubate her. She is begging them, no, no, no. Jonah, what you said, they're like, don't, please, whatever you do, don't do this. That patient who's begging and pushing away at tubes and stuff doesn't want it for this reason. Likely they have already had the tube sometime in the past and were put on a ventilator. And they woke up in ICU from an asthma attack with a tube in their mouth and this machine breathing for them. The human body is lazy. If I breathe for you through a ventilating device, your pons in your brain will say, oh, hell, I'm not needed. I'll go do something else. They don't need me anymore. I'm going to shut off. The respiratory drive goes away because the body just won't keep anything active that's not being used. If you don't use your muscles, they go away, right? If you don't walk, your feet become baby smooth now, right? They lose the calluses. If you don't use the receptors, they go away. And you have to wake them back up. And so we call that weaning them off the ventilator. The more often you're put on a ventilator, the harder it is to wean you off of a ventilator. And plus, nobody wants to wake up with a tube in their mouth, unable to speak, unable to eat normally. Does that make sense? Now, we don't want to get there, but I will, as a paramedic will get you there before you die, I hope, before you go into arrest. That's a decision line for the paramedic right there where he or she goes, you're in really bad shape, and I think if I remove your airway and your ability to breathe, I can do a better job than you can. Now, there's this old rule. Who can control your airway better than you? No one. Who can protect your airway better than you? No one. Who can breathe for you better than you? No one. And so when you cross a line and you're in such bad a shape that somebody else determines they can, you're in really, really bad shape. Guys, this is a life-threatening emergency here. This is a life-threatening emergency. She hadn't had an asthma attack in years. It was a childhood thing. Here she is, an 18-year-old woman, stressed out for a skills exam, and she almost dies. She almost dies because of anxiety-induced asthma attack. Anything can set it off. I say anything, a number of things. Exercise, exposure to temperature changes, pollens, allergens, stuff like that in the air. So we got to interrupt it. How do we interrupt it? We have to use the patient's rescue inhaler. We have to assist them with it at the EMT level. You don't have anything else. With that being said, if I get there and they're still in an asthma attack, and they've used their inhaler, hey, this is an automatic. I need a paramedic here. I need ALS here. This thing is obviously status, and it's still going on. You're going to see the status word again in epilepsy. Status epilepticus just means you arrive on scene. They've been having epilepsy for 5 minutes without interruption, blah, blah, blah. So we'll see that again, and that's a life-threatening emergency as well. Any questions on asthma? Their beta 2 bronchodilator is what they need. We don't pull it out of the bag of tricks as an EMT. We have to assist them with theirs. But I can give them oxygen, and that oxygen should be humidified. There's that thick, mucousy, high viscosity stuff that builds up in there. Jordan, where's your inhaler now that I know that you have asthma?
Not in my bag, but I will put it in my bag.
Please.
I promise.
Please. Because I might stress you out to the point where you start wheezing. And
Sometimes
I
don't know.
I kicked a student out one time for grades. I'm like, you're not cutting it. You got to go. And she had an asthma attack in my office, and she slumped over on my desk. And she was drooling and starting to turn blue, and I'm like, where is your inhaler? Because I don't have one. I'm about to call 911, and all she could get out was, car, and I'm like, where is your car? It's not here, so I'm not going to go look for it. I'm allergic to bees, and I'm harvesting honey, but I don't know where my EpiPen is. Smart. Please carry it with you, okay? Because Murphy's Law will do what? Murphy has found an opening. If you come back tomorrow and say, I had an asthma attack last night, we'll blame Murphy. More prevalent in females, triggered by infections and stuff like that. So we know what that looks like. What do you think the signs and symptoms look like? What's the signs and symptoms of asthma?
Shortness of breath, shallow breathing,
Wheezing. Altered mental status, cyanosis, maybe in the later stages. How do we work it? Oxygen at 94. These people tend to do something what we call air trapping. Jordan will know exactly what I'm talking about. They're hurting for air so bad that they really just don't take the time to exhale. So if you can coach them to exhale out before they take that next breath, at least they'll get fresh, what I call fresh. At least they'll not be moving just dead space air. At least they'll be moving some more atmosphere in. Does that make sense? Now that's hard to do because you're in a total panic mode. And these kids will come at you because they're so anxious. And consider CPAP. That will help. And then the beta-2 agonist, once again, it has to be theirs, okay? It has to be theirs. I'm going to catch my breath for a moment and pause for reflection and questions. Are you now kind of seeing what that hell week we went through last week is doing now? The application of all of that A&P physiology stuff. It's coming to surface now in these disease processes. Think about it. Please think about it. If I didn't teach you alpha-beta dopaminergic, would you know what this is? If I didn't teach you agonist versus antagonist, would you know what that was? Now when you read that, what do you know, Christian? What do you know that is? That's a drug that opens up the bronchial tree. I've done this a long time, and oftentimes I hear from students, and in the first week or two, they're like, "This is too much. Do we really have to know this?" Blah blah blah. All those feedbacks I get, and the answer is, "Yep." It said medical, and it said emergency. So by its very nature, it's a difficult concept. I told you I'd shut up and pause for reflection. Questions?
This is back on that beta, what I just saw. What does beta 1 do again?
Heart.
All right, okay.
If it's a beta-1 agonist, increasing everything. Speed, contractility, conductivity. If it's a beta-1 antagonist, it slows it down, also known as beta blockers.
Alpha 1 and 2.
Alpha 1 and 2, periphery. Alpha 1 shrinks the vessels out here at the far ends and pulls the blood to the core. Alpha 2 says not so much. Dopaminergic, dealing with the kidneys and their role in water balance, fluid balance, pH balance. We have a hidden demon in this lecture today. There's a demon in this lecture. And we don't speak of this demon too much. We've obviously spoken of hypoxia, haven't we? Because all these conditions will lead to hypoxia, thus hypoxemia. But what's the real demon here? As related to hypoxia. What's the real demon here? Do what?
Smoking.
Well, that's a great cause. Yeah, I would 100% agree with you. That's the demon, and I would say that COPD is the devil's disease.
CO2.
Keep going. CO2 retention, increased levels of CO2 combining with
Low levels of
Low levels of O2 is leading to what type of metabolism? Anaerobic metabolism, without air. Ana, without air, air, aerobic. Anaerobic metabolism. That's the demon. So, all these patients can progress to anaerobic metabolism. Therefore, they start retaining CO2. It's twofold, guys. They're making more CO2 because of anaerobic metabolism, and they cannot do what with it? Eliminate it. So, Luke, they start retaining what they're building more of. It's kind of like a 1-2 punch, isn't it? It's kind of like interest rates on your savings account. I'm saving, plus I'm getting interest. They're making more, plus they can't get rid of it. What would you expect an asthma patient's CO2 capnography reading to be during the attack? If the normal range is 35 to 45, what do you expect their CO2 reading to be during the attack? Below. Because they're not blowing it off. They can't get rid of it. Once you administer their bronchodilator and it relieves the bronchial tree, what do you expect their entitled CO2 reading to be? Higher than 45. You can know by this thing I will show you later. Monday, actually, I'll show you. We'll have a capnography lecture. And you will know when your bronchodilator started working because the peak of that went up. There's another thing you'll know with that Monday as well. So that'll be a super cool lecture, especially if you like to see visualization. Everything we talked about can be graphed, by the way. Yes?
Are we off next Monday?
Well, damn. Stare it.
Is our test not Tuesday?
Well, darn.
They gave us 3 days.
I guess I'll have to show you that on Wednesday. Yes and yes. Yes, we're off Monday. It's Labor Day. It's a holiday. College is closed. Don't show up. Tuesday, when you come back, we'll take our exam.
Are we taking our test in class, or are we having?
We'll take it. We'll take that one in class just so I make sure everybody can get in here and get it done. And then from here forward, we'll do it in the testing center. Unless I change my mind on that, which I don't plan on doing so. Good point, good point, good point. Thank you. Thank you. I'm going to review the exam between now and Tuesday myself. Probably real quick, like in the next 24 hours, I'll review the exam. I may do that while you guys are rotating through skill stations tomorrow. And I want to make sure that that study guide I gave you is still accurate. And I want to make sure that there's nothing on the exam that we haven't lectured over yet. Just to be sure. Just to be sure.
Some stuff that we haven't gone over. That's
How many
on the
questions
review.
do you have?
Don't quote me, I think 70. Multiple choice.
That's how many questions?
Don't quote me on that. I actually could look right quick.
Is that one timed?
I'll run a timer so you can pace yourself, but I won't cut you off. Now, toward the end, I want you to have your pace established.
How much time do you have on the actual
Registry? I don't know.
I took the practice.
They'll tell you.
I took the practice one and it was practicing over 2 hours.
If you go to nremt.org, you can see samples of it, and it'll give you more information about that exam. It'll actually give you the breakout of how much of what.
70 questions on just the respiratory.
We've done pneumonia. We talked about PE the other day, so this is in the PowerPoint as well. I really don't want to repeat that. We talked about pulmonary edema the other day when fluid backs up due to the heart being bad. We talked about pink frothy sputum. We didn't talk, well, we kind of talked about pneumothorax. I'll probably need to revisit that a little bit more, and I will. I'm just kind of seeing where we're at, guys, so don't worry about trying to write everything down here. I talked about epiglottitis. I'm not going to go into whooping cough, cystic fibrosis. I'm not doing this. So there's that meter dose inhaler. They come in, you know, obviously this one's for a small child. It's got the bear and stuff on it. This one would be more of an adult. We'll show and tell and play with those tomorrow. We'll show and tell and play with this tomorrow. Who can tell me what size the connector is up here? 15 by 22. Can the nebulizer, I call these peace pipes, but these are self-administered. I never liked them in the field because most of my patients were so weak they wouldn't hold those up to their face, so the face mask worked better. And I also found out if I had like a little respiratory cold myself, if I was around that and then closed back the ambulance, I actually started breathing a little better because you're going to get a little bit of it yourself just because you're going to be right there with it.
I don't know what it's called, but when I used to work in ICU, respiratory had them, and there's like this purple tube that they have, and you can connect your inhaler to it.
Yep.
And it'll make
And what size is that connection? 15 by 22. Yep. Yep, you're correct. You can put the additional medication in there with it. Oh, this is just a laundry list. I would not necessarily have to memorize that, but these are beta 2 agonist or bronchodilators.
Do they all do the same thing?
Basically, they just got a little bit of different mechanism of action. Some work better than others for certain people. Everybody's built different. Some are more expensive than others. Some of them kind of give you a 1-2 punch with it. Some of them you only administer one time. You can't repeat it. Some of them have a peanut base, and so if you got a peanut allergy, you can't use them. So that's why they make a bunch of different ones. Why would you get tachycardic, tremor, nervous, dry mouth, nausea, and vomiting? Yep, because it's working on the sympathetic nervous system, right? So here's the skills that we'll do tomorrow. If you want to flip through your slides and see those for tomorrow, please do so. Anyway, it gets a little windy. No pun intended. Any other questions? So wear pants tomorrow, no shorts. My bad. Closed-toed shoes. And then we'll do everything that we normally do. We'll divide up, conquer.